Let me just go ahead and get started. It is week 6. We are halfway through, and it starts to get a little bit scary now for you. You have a lot of projects due for me, also community. You're going to be loaded up with exams and HESIs, and it's now the time where don't get behind. Try to keep ahead as much as possible. Next week, we're going to do exam 2. Anybody who wants to meet with me, you're more than willing to send me a message. I'll meet with you. I am doing a Friday review. Initially, I put it down for Thursday, but I had a physician's visit for my infusion, so I have to get that. So I made it for Friday at 2 o'clock. So I will record it, of course, and it will be posted as soon as I do get everybody's review. You already have the information, you already have the study guide, and you can always go to my YouTube channel and look at last term's review. It's similar, very, very similar, not like a whole crazy amount of changes. So you can use it and it will work, all right? So week 6, we're going to go over chapters 43, 44. It's hematology, immunology, dysfunction, and children with cancer. We're going to go into some of the cancers. Remember, CJ Sims is due and NCLEX questions. Make sure that you get them in timely. If not, I'm sending you messages to make sure. CJ Sims and NCLEX questions do carry together 11% of your grade. So when you add into 78 as your KGA, that's your exams, that's your quizzes and your HESI, you add in a low grade, it's 20%, you're not going to pass. So just be very aware. All I tell you is, I know you guys are busy. And I know that you're trying to pick to choose what you need to get done because I understand. But homework in minimum 78, don't let it pull your grade down. I've seen homework fails, and I don't want that for anybody, okay? So it's just a warning. Your homework grades are on right now from week 6 up to week 8, and then I turn them back off. So right now you're seeing how homework does affect your grades. And most of the times it's better. Sometimes it could be down a little bit, and it's the homework that's doing that. So any questions? Remember to get in your pediatric assessment project, your diagnosis, what you want. That modules in week 8 has it listed there. There is a page that has a whole bunch of different diagnoses. You do not have to use them. I put them there to say, here's some things. Would you like to use these? Or something else that could be a pediatric diagnosis you can use. Just send it to me and I'll approve it for you. If I can make it into a pediatric diagnosis, I'll work with you if that's what you want to do, okay? So let's go ahead. Let's start with our PowerPoint. So let's start with hematology, immunology. Talking about hemoglobin, hematocrit, blood clotting, platelets, and then of course immune function, which we'll talk about, like your white blood cells, right? Neutrophils, which is all about immune. So in order to evaluate immune dysfunction, it's not just a history and physical that gets us starting to consider what's going on, but it's a simple CBC. Now, a CBC looks at a white blood cell. That looks at your immune system. Is it too high? Bacterial infection. Too low? Maybe you're down to the point of leukemia. So looking at white blood cells can give you a clue. Also, hemoglobin, hematocrit. Why is my child so tired, lacking energy, and doesn't want to move? Well, they could have some type of anemia. And that could be told by just looking at a simple CBC. Also, one of the things that is in the bleeding cascade to help clot blood is platelets. And we don't think about platelets as bleeding things that help stop blood, but it does. And without platelets, normals are above 100,000, usually 2, 3, 400,000 platelets. That's normal. Now, with a child, that would be a low platelets, and we're going to get up to some conditions that cause that. It could be 10,000. So platelet counts of 10,000, bleeding precautions. This child is going to bleed, ecchymosis and, petechiae and maybe even epistaxis will be going on. So again, just the CBC could show us that stuff. Now, food, dairy of poor iron sources. Think about the toddler and the way they eat. They don't eat green leafy vegetables and all the good stuff with the iron in it, do they? They want chicken nuggets, macaroni, cheese, and apple juice, and they don't want all of those vegetables and things that could boost their iron. And we know toddlers are anorexic. They don't eat that much. And this is a time where they can get lower hemoglobin hematocrits. Because unlike the infants, we're giving them iron some way all the way through. At 6 months, we start iron fortified formulas and in iron fortified cereals. And now we're giving foods that are high in iron. But, infants take it. They don't understand. They eat whatever mom gives them. They become toddlers and they have minds of their own. And now they're not eating. And that does lead to anemia because of that picky, finicky eating. So it's something to look for. The kid's getting really tired, really fatigued. This would be a child that we would look at to give something, either a diet or supplements. Another thing we look at with the immunological, with the white count, is are we sick all the time? What's going on? My kid's always sick. And of course, any evidence of bleeding. That's the platelet part, right? Any ecchymosis, petechiae, nosebleeds, anything going on. Now, anemia, most common hematological disorder. It happens, well, we know with toddlers, that's because of their diet, and almost every toddler goes through that. Unless you're my grandson who loves broccoli, and he would just eat chunks and trees of it, and still to this day, chunks and trees, no butter, no salt, broccoli. Okay, you're not going to be anemic, that's for sure. But anyway, most kids are not like that. So, what happens? Let's think about red blood cells and why all these symptoms happen. What do red blood cells do? They carry oxygen and they carry iron. So if you don't have a lot of red blood cells, you have a lack of oxygen. Tire easy, no oxygen. Makes sense, right? Also, not enough cells, decreased iron. Food, no gasoline for the cells. They're not going to want to move. So that's why that tired, that, lethargic feeling comes in because you don't have enough iron and oxygen. Now, what also happens, some way the cells die, or how do we get these red blood cell disorders? Some of it is the cells die quick. Sometimes it's the shape or the size of them, and it's something that we will look at. And sometimes they're not even produced that look correctly. Now, they say that a hemoglobin less than 10 in a child is considered to be anemic, except for toddlers. It can be a little bit lower because we know they're going to be a little lower. But 10, any other normal child, below that, we will say they're anemic. Now, you get this kid in, mom saying they're tired. You're suspecting anemia. You're seeing the kid does look a little pale. All that, signs, symptoms, classic textbook. All right. So then you're going to do your assessment. So besides that physical look, and you could see the paleness, now you're going to listen to the chest, and let's listen to those heart sounds. Now, heart sounds usually are chikum, 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 right? Very simply. When you have anemia, the blood cells are usually packed inside blood vessels. So they can't move. So they just swoosh through. So chikum, chikum, chikum. You don't hear them. But when they're less, they bounce off of each other. And you hear it's a swooshy because they're swooshing through because they're bouncing off of each other. And you really can hear it. Okay. Along with what else would you see with anemia? Tachycardia, right? Because the heart's trying really hard to get oxygen and iron to the body. So what happens if we don't take care of it? The heart's beating faster, you don't have oxygen, you're going to go into failure. The heart's going to keep trying, keep trying, keep trying. You're going to see the child look more blue. And then, of course, there's going to be things with growth retardation, whether it's delay or even body physically growing. You don't put gasoline in the tank, no nutrition, iron, oxygen to move, the body's not going to grow. So then you see that body, you'll see them shorter type things. Now, types of anemia. Well, we've mentioned nutrition. That one you got. That is your iron deficient anemia. B12 is another one they talk about, the intrinsic factor in the stomach. Those two we think about. How do we treat them? Replace the iron or increase it in the diet. It's either or. Now, another decreased red blood cell production is something called aplastic anemia, and it's bone marrow failures going on now. So your body's not producing enough cells. In aplastic anemia, it's all types of cells. It's your red blood cells, it's your white blood cells, and your platelets. We'll go into that in a second. Also, it's your cancers, your lymphocytic leukemia, myelolytic leukemia, AML, ALL, both of those. And then it could be some overwhelming septic viral infection, bone marrow failure. Your bone marrow stops producing. Another thing that can get rid of blood quick is just simple old blood loss, right? Nosebleeds. You would be surprised how many nosebleeds or epistaxis that I saw come into the emergency room, that it's their third, fourth nosebleed in the last 2 weeks or 3 weeks or month or whatever, but more than normal. They've gone to the doctor, they get tired. I'm going right to the ER. Let's go to the people who know what they're doing, the emergency room, right? And we listen to the signs, the symptoms, and nosebleeds could be bleeding coagulopathies. It could be hemophilia. It could be ITP. And I'll go into the P for platelets. That's where the platelets come in. Or it could be DIC, overwhelming body sepsis, and many registered nurses don't understand the complete concept of DIC. It is a lot of bleeding coagulopathies, and you're giving heparin, and it's just one of those. You'll have two nurses to one patient. That's how sick that patient will be, whether an adult or child. Now, increased red blood cell production. So you are producing cells. You do that in sickle cell, and you do that in thalassemia. Now, sickle cell anemia, you've heard about it. It's those African American, it's cultural, that has a tendency, and there are these C or sickle shaped cells. Now, and they die quick. Most children coming in the ER for the sickle cell crisis all come in with low hemoglobin and hematocrits. I would be happy if a sickle cell child came into the ER with a hemoglobin of 7. That would be a good one. They're usually 5 and 15, 6 and 18, really low, and they require blood in the ER. They're hypoxic. They need, their body, their organs need oxygen. So they do get blood right into the ER. So sickle cell, that one dies quick. The other one, thalassemia. And I call them the rectangular shaped cells, and these are from Mediterranean descent. And again, they die quick. I'm going to go into that more in a second. And then the other increased red blood cell destruction is due to some chemical event, whether it's chemotherapy, radiation, toxic shock, something going on that can also destroy your red blood cells. So, management. How are we going to manage these children? Anemia. Well, number one, you got to diagnose them. You've got to look and assess the child. So do the history, do the physical, find out. Listen for that murmur. Can you hear it or not? And of course, simple, basic CBC. Now, yes, they'll do a bunch of other tests, but it's that CBC that tells us everything. Just a simple little thing like that. Now, one of the things, and you're going to hear me constantly through this course, are you going to treat a symptom or are you going to treat the cause of that symptom? And the goal is to treat why it happened, the cause. Now, and I'm going to go into what that means in a second. For instance, what what's to say that we have hemorrhaging going on and we're giving transfusions? Well, why are we hemorrhaging, or is it nutritional? Is it a simple GI bleed? Don't rule out, the simple. Don't forget about those things because it could be a GI bleed going on that nobody has diagnosed yet. Now, when these children come in and they're anemic. And, let's say they come in, let's say through the emergency room. One of the first things we'll do is to start an IV, get them some support, giving them some sugar in an IV. Many of them are too weak. They don't want to eat because they have no energy. And it also, we're giving fluid to replace the blood in the vessels because there's no cells. So it needs volume to flow around easier. Um, the other thing we may do is give oxygen therapy. But I'm going to pose you this question. If I only have this many red blood cells, is extra oxygen going to make it better? Maybe, maybe not, right? You don't have red blood cells. That's the problem. It's not that you don't have oxygen, you do, but you don't have many of them. So they do to maximize whatever's there, they'll put on some oxygen. And again, it is a controversial. I would put it on just because it looks good, makes me feel better, like I've done something. And then, of course, any child that's anemic, you're going to have them on bed rest. You're going to do bundle care, cluster care. You're not going to overtire them because they'll tire easily. So again, assessing how old is the child? What is their background? Right? African American, Mediterranean, or not? Doing that history, finding out when did these symptoms start? What did you start to see? Anything else? Any other sicknesses and whatnot? Of course, simple. Do that stool for occult blood. It could be a simple, ulcer. Yes, kids do get ulcers. Some are little worry warts, and they do. They get ulcers. Um, Also, as we are getting into, okay, they're anemic, they're going to require blood testings, they're going to maybe require blood transfusions, whatnot in the future. Always, always let the child know what's going on and why you're doing what you're doing. And get the child involved. I would have them pick the needle where it's going to go and where they wanted me to numb it. And then they would hold their stuffy real tight, and mommy would hold their hand, and it would be no big deal. Again, you got a child who's anemic. They already tire easily. You don't want them screaming and yelling every time you need to go draw blood because you're burning too much energy. So that's to decrease the amount of oxygen that that child needs because you don't overstress them. Okay, that's preventing. That's helping that child. Now, iron deficient anemia is because they don't need enough iron. Well, we know that toddlers a really good place to put the beginnings of iron deficient anemia. We know, as I said, infants get iron fortified formulas and cereals growing up, and breast milk and vitamin D for those babies keeps them with enough iron. We don't stop iron fortified formulas till 1 year old. And at 1 year, we can give them whole milk. Now, if we gave whole milk earlier, they still don't have iron in their body. And that's what's called a milk baby. Many years ago, instead of giving formula, it's cheaper to give whole milk. So some parents were just giving whole milk to their babies, not realizing that they needed the calcium and other stuff in the formula, especially the iron for the baby. So, how do we take care of this? Number one, try to change their diet. Today they've got juices that are vegetables that don't taste bad. There's ways to trick the kids into doing things. And then some kids, like my grandson, didn't care and still doesn't care. Give me my broccoli and he'll steal my off my plate too. And then the other thing Is some children resistant? You need to put them on iron supplementation. Do you remember how to give oral iron to a child? Liquid iron. Remember, it's through a straw on an empty stomach because the gastric acid needs to break down the iron so their body can use it. It's better if you take it with orange juice. That extra acid helps break down the iron in the stomach because that's where it's metabolized and used from the stomach. Never milk, never after a meal, before meals, empty stomach with orange juice through a straw. And remember, those stools are going to turn a nasty, gooey black. Warn the parents because that's scary. Oh my God, look what he just had. Oh, what are we going to do? And you're like, oh, that's the iron I forgot to tell you, parent. Sickle cell. If both parents have the trait, each child has a 25% chance of the disease. Okay? Sickle cell disease. African American, we know that that's where we see many. Now, let me explain sickle cell my way. And hopefully, this is going to help you understand it so you know how to treat it. We want to treat the cause of it, we don't want to treat symptoms. This is what I was talking about. So, sickle cell disease, we know that the cells are in a shape of a C, a sickle. And we know the blood goes through the body and bifurcates and bifurcates and bifurcates into smaller and smaller vessels. And many times, children especially don't keep well hydrated in the sun, out playing, forget to drink, etc., etc. And those vessels get small. And what happens in sickle cell, this little cell comes down, and at the bifurcation, it gets stuck and covers it completely up. What happens? No cells can go down. So below that, there's no blood going except for other capillaries, the way it's filling it. But literally, there's decreased blood flow going down below it. Now, that blood cell is covering the way the blood is coming in the vessel. So, what happens is blood backs up, causes all this swelling, pain, heat, redness, and that's when they go in for a sickle cell crisis. So, what's the cause of that crisis? Dehydration and small vessels. So, how do you think, and what do you think priority treatment for sickle cell would be? We got to
So,
dilate the blood vessels. How do we do that? Child comes in, get an IV in, IV bolus right now. Let's get those vessels as big as we can. And of course, have the kid calm, sitting in mommy's lap, wherever they want to sit, so they're not burning energy and getting that fluid in. Now, sickle cell hurt. Sickle cell crisis, they are whimpering and crying. They hurt. In the other hand, I have morphine or hydromorphone or whatever the pain medicine is. But remember, priority for sickle cell is to dilate the vessel. Let's unhinge that little cell to get it moving through. We're also going to put heat on it to dilate it more. Where is it? The knee? Is it the elbow? Where is that sickle cell crisis? What causes sickle cells? Well, as I said, it's dehydration. What can cause problems with smaller blood vessels? Well, trauma, infection, fever, stress, dehydration, all the above. So, one of the things with sickle cell is, and any child immunosuppressed, if they have a temperature, a fever of 100.5 and higher, they are told to call the doctor or to go get treatment now. They don't have immune systems. They are immunosuppressed, whether they're rheumatoid arthritis, cystic fibrosis, Sickle cell, it doesn't matter. Immunosuppressed, 100.5. They need to go get antibiotics, or the doctor needs to call them in, whatever the arrangement there is. So, sickle cell child comes in. Many times, even bigger children, parents are pushing them in on wheelchairs. They can't even walk. They're so pale. They're in so much pain. So we get him into a room, get him comfortable, get an IV in him, draw whatever labs we need, because we need to look at, potassium. We need to look at where is our hemoglobin, hematocrit. Do we have an infection? Is it bacterial? Look at the white cells, look at the platelets, because part of that, it could be also hurt within sickle cell. So getting that bolus, getting them their pain medicine, and then let them rest and keep them as calm as possible. Usually, these children are admitted for follow-up IV antibiotics upstairs. If their hemoglobin hematocrit is very low, they're going to start blood down in the ER, go upstairs, finish it, and maybe even get another, bag of blood. Who knows? It depends on how low it was. One of the things we do for young children, remember, young children don't have a big immune system, right? I've told you, when we get to be toddlers and preschoolers, our immune systems are built because they swap spit all day long in daycare and school, sharing stuff and pens and toys and everything in the mouth, and all the germs fly around, right? So that's how they boost their immune system. Well, sickle cell children are immunosuppressed. They really can't do that like a child without sickle cell. These children are on prophylactic antibiotics from 2 months to about 5 years. That's when they say the immune system's going through the biggest, gaining all the virals from, all of these children swapping all their germs for many years, right? But at 5 years old, they stop giving prophylactics, and that's when we usually start to see these little sickle cell things starting and the crises occur. Another thing we'll do is we'll monitor reticulocyte count. Let's see how bone marrow's working. Are they producing cells still? What do they look like, et cetera, et cetera. And of course, I said blood transfusion, because these children on this very low hemoglobin hematocrit, there's no energy. And we need to boost that quick, and the body does need that oxygen and the iron from the blood. Now, there's no cure, maybe a bone marrow transplant. It's not really said for sure yet. Our biggest concern is the infections that we get. As I said, at 100.5, they need to get antibiotics. If that doesn't take care of it, they need to go get to the ER for medical care, because what is the leading cause of death is bacterial infections. So when they get that first fever, they need to go, because it's just going to go into septic shock quick, because there's no immune system, not an adequate enough one to fight it. So our job as nurses is to educate. So early interventions for problems. You see that fever or you start the pain. They do have pain medicine at home. They can take it. It's usually like a Tylenol with a little bit of codeine in it. The 15 milligrams and 30 milligrams, smaller pills, but works really great on children. And that can help with the pain. They start with fever, they need to call their doctor. They need to take care of it. Another thing is, yes, they're going to take their penicillin for the first like 5 years of life, but know that a stroke can mimic a sickle cell crisis in the brain. There's blood vessels there, right? There's blood vessels in the eye. There's blood vessels in the lungs, and it could look like pulmonary embolus, could look like stroke. You got to be careful, right? So don't say it was just a sickle cell. It could be more than. So again, that's why you recognize the signs. What is it? Is it something serious? How quick do I got to get to the hospital? Now, we talked about a sickle shape. Well, this is our rectangular shape, like thalassemia. It is anemia, and it's a shortened life of red blood cells, just like your sickle cell. It's mainly descendants of people living near the Mediterranean Sea, and I call them the rectangle shapes. Now, when we test and we look at sickle cell, I mean, thalassemia, there's all different types of it, but we're only test on the last one, thalassemia major or Cooley's anemia. It's usually you get questions, they're telling you about Cooley's anemia, and that's where they want the answers from. Now, what happens with thalassemia? It's different than sickle cell. There's no crises, that pain sort of thing. What happens is the blood cells burst and spew iron and oxygen into the blood vessels. So you're lost oxygen, and now you're going to become iron toxic from the iron of the cells. That's how much cells are bursting in there. Now, you're going to say, how do we know if we have this thalassemia? This isn't one that you're born with. You're born with normal cells, and then about at 6 weeks, you start to see them changing. And the symptoms that you would see is if you don't have blood, you don't have oxygen, you don't have iron, you don't have nutrition for that infant, the brain, right? So cognitively, the child's not going to be lifting their head or trying to turn or sucking, swallowing, breathing. There will be delayed, and it will make you look what's going on here. And doing a CBC is going to be showing those cell changes, and that will give the clue it's thalassemia. Now, thalassemia, Cooley's thalassemia major, the only treatment, cells die, die, die. So I got to get rid of that iron chelation therapy, or apheresis, which is like a dialysis sort of thing. Nurses run those machines. And, this is a person, it's transfusions. Now, the biggest concern, with those transfusions is they get a lot of them. This is the way they live. So, what if they have a really rare blood type? That's one of the big concerns. And again, can you imagine you're going to chelation therapy, apheresis, you're going in for blood transfusions, or you're going to get your, CBC tested, a blood, and it's a lot of work for families and for the children. So it needs that special people to do this one, right? Now, what happens with thalassemia is this. So, as I said, all your blood cells, they start dying quick. So your hemoglobin goes low. And then you give some blood, and now your hemoglobin's high. Oh, and then the blood cells die, and now it's low. This going from low to low to high hemoglobin wreaks havoc on the heart. Because the heart has to beat fast and then it can slow down. And it has to beat really fast when it's anemic and slow right down. And now it's working and working, and it goes into failure. That's the heart disease, what they're talking about. Also, because the spleen is producing these cells that are dying right away and causing iron problems, et cetera, they take the spleen out. Many times, immunosuppressed, they get post-splenectomy sepsis, which could cause multi-organ failure and death. So, thalassemia, again, maybe bone marrow, they're not really sure, but it is a life of blood transfusions and iron chelation therapy. Now, aplastic anemia, it is white blood cells, hemoglobin, hematocrit, and platelets all are suppressed. Profound anemia, leukopenia, which means low white blood cells, thrombocytopenia, low platelet count, simultaneous all together. So you're bleeding, you're tired, and you are just weak. Can you imagine all of those? They treat it just like they treat chemotherapy with leukemia. Same sort of therapy they try, and they try to knock out the bad cells and let the good cells come. Again, it's like leukemia. Does it work? It's going to sometimes take time for it to work, or sometimes, there is a cure. Hemostasis, this is hemophilia. Now, when your blood doesn't clot, we call it hemophilia. Hemophilia is saying one of the components of the bleeding cascade is missing. One of the factors, one of the things that helps blood clot is not there. So if you don't have all of them, you're going to continue to bleed because there's nothing to say, hey, stop, put a dam on it, and it continues to bleed. Now, we always hear about X factor, factor 8, right? It's the one you hear about, but there's more than that. Now, hemophilia comes from mom, X-linked recessive. There are 3 different types of hemophilia listed here: factor 8, factor 9, and then there is another factor. It could be factor 10, who knows? But apparently, this researcher called von Willebrand found the clotting factor, and he put his name on it instead of putting a number. Now, von Willebrand, I've seen quite a few of this one, believe it or not. More than 8, which is quite surprising. But von Willebrand is that factor, factor 10, let's say, and factor 8 together, and they do bleed, bleed, bleed. So, how do you diagnose? Well, let's say you didn't know. What usually you'll start to see is telltale signs. It could happen at birth where the umbilicus, you can't get it to stop bleeding after you cut it at birth, or maybe you did a circumcision, didn't know, and now it's bleeding. I mean, or your IVs, you're seeing ecchymotic areas. That could give you, or if they're older, it's worried about all of those bleeding type things. Now, usually with hemophilia, if they're cut, they're going to bleed. It's overt, it's there, put pressure on it, and they're going to have to give that factor to stop that blood if it's that big incision. Sometimes they fall, and bleeding is inside a joint sac, like a knee. The knee is always the one that they get in. And that blood will destroy the joint sac. So now you're worried about crippling for later on. So trying to decrease the amount of blood that goes into the knees, right? It's going to decreases the chance of that crippling and need for maybe a wheelchair later on in life, right? So hemarthrosis, and then of course ecchymosis, we will see all over. Now, again, X-linked, like I said, recessive, it's from mommy. Now, child comes in, it's going to need a diagnosis. We are suspecting some sort of hemophilia. So we're doing CBC, of course. We're going to be doing a PT, a PTT, and then some other levels, and then factor 8, factor 9, a factor von Willebrand's, and sending them out to labs. And all of that stuff we're not going to see for a week or more. They're always specialty labs. So what do we get in our hands right away? Well, we get the CBC, which is that platelet count. It's normal. And we get the PTT. That's for heparin. It's prolonged, like 200, 300. It's long. So normal platelets, prolonged PTT, most likely this is what we call hemophilia. What type? We don't know until we get all the factors back from those specialty labs that we sent it out at. Now, I'll tell you a little story about a little 9-year-old, 8 or 9-year-old little boy who came in with his daddy one Saturday morning. He had fallen down. He had hurt his knee, and it was swollen, and it was ecchymotic. And he couldn't get a hold of his hematologist. So he didn't know what to do. Should he give to home therapy? But he had brought it with him. The father did, to be sure. And our physician said, go ahead. So I was there on duty, and I actually had a brand new nurse orienting with me, new to nursing, brand new nurse. And the father says to me, do you mind if I give it? And I'm like, your son? Do you mind if we watch? And he goes, not at all. I watched this father and son look at his arm, pick a vessel. I watched him go wash his hands, put gloves on, set the equipment up, do better technique than most nurses do, and administered, put a butterfly in, and it was like almost 15 or 20 mLs. Slowly pushed it in, took it out, put a Band-Aid on. The boy and the father did it together. Best thing I've ever seen in my life. So it can be done. It can be done well. There was no bruising. I mean, I was like, I bowed down to him like this when he was done, saying, "You have just far exceeded anything I've ever seen." I'm OCD picky, but I think you're right up there with me on that level. So again, I had to share it with y'all. Now, sometimes we have a milder hemophilia that don't need the IV aggressive home therapy factor thing. And we can give something called desmopressin. Now, next week, you're going to find out it's also used for a pituitary problem called diabetes insipidus. It corrects that, but it's also used for mild hemophilia. And they do have nasal sprays on that one. So that's usually what they send them home with. Now you get your little toddler home and you find out he has hemophilia, and now what do? Number one, protect the house, protect the child. Look at the coffee table, sharp edges. Remember, anything sharp, they'll hurt themselves. Number one, safe environment. And of course, dental hygiene, soft toothbrushes, all of those things. Now, when we get to the point you get a sprained ankle, go to musculoskeletal, week 9, we're going to talk about rice. Well, we do this for hemophilia too. So, okay, you got a child who's bleeding, who's hemophilia. Number one, kids, depending on their age, don't like blood, right? They scared to death. Their insides are coming out and they're going to die. So, number one, calm the child down. You're going to sit them, rest them, ice it, compress it, and elevate it. And then if they get the factor, they get the factor. But that's exactly how we treat it. And that decreases the amount of blood that's going to go into that knee joint and prevent that crippling that could go on. The goal in hemophilia is to prevent big bleeds and to prevent and protect joints. That's our big goal here. Yeah, there's gene therapies in there. It's not completely done, but they are working on it. Now, I told you about ITP, right? Immune thrombocytopenia purpura, E for platelets, low platelet counts, below 20,000. This is bleeding precautions. What happened? Why do you get this? Well, the cause is it's an upper respiratory infection, some sickness just recently, and it causes destruction of platelets. Now, these children usually come into the ER because they're having nosebleeds, epistaxis, frequent. Also, you might see like that little purple, like little dots there, like on the legs and arms, or big ecchymotic areas. So we're seeing bleeding. Remember, platelets, you don't have it, you're going to bleed, whether inside the body, ecchymosis or purpura, those things. So, child's admitted to the hospital. We're going to be given IVIG and we're going to be given anti-D. And you, as a nurse, what's your responsibility? They're on bleeding precautions. Number one, it's teaching. That teenage girl, let's say it is, tell her she can't shave her legs while on, this going on because if it nicks, she's going to bleed. Or the man, young teenager, no shaving, right? Bleeding precautions. Toothbrushes, soft ones, even flossing to be gentle, not to, really cause bleeding gums because it will. No venipunctures. Usually these children will come in, they'll have an IV, and we will draw the labs right out of the IV instead of sticking them anti-cube for every single blood stick. And you will be monitoring daily what those labs are. Of course, always looking at the child. Do you see any bleeding tissues? Are they coughing blood, blowing blood? Are they urinating stool? Anything. Look for bruising, anything going on that would be monitored for. And we're going to give corticosteroids. This says sometimes, but just say, 9 out of 10 times. Corticosteroids will be given with it, and that will be the treatment. Now, after 1 year of treatment, because sometimes it can go on that long, They call it chronic ITP. But usually we can take care of it with the IVIG and anti-D, and it's just an acute stage, and we can take care of it. Epistaxis. Have you had the NCLEX question yet on epistaxis? Because it's coming up. You'll see it. What do? A child is bleeding blood out of their nose. Well, number one, they're bleeding blood out of their nose. They're having a moment, most of them. I'm going to die, right? So, again, calm the child down. Sit him on the mother's lap or wherever they want to sit. Take your finger, your forefinger and thumb, put it on the bridge of the nose, and you lean them forward. And you lean them forward because you don't want to put them back and let them swallow all the blood. So if you put it forward, it can drip out and it's not going to be vomiting clots of stuff after you finally get that nosebleed stopped. Okay. Now, after 10 minutes, if you release that grip and they're still bleeding, they need to get medical attention. Whether it's going in and get nose tampons or going to the OR, be cauterized, whatever it is, it needs to go. But I'm saying it's usually how we find out children do have bleeding coagulopathies like ITP. That's one of the ways that we've caught it from a nosebleed. Now, immune system, HIV/AIDS. We don't deal with pregnant mothers in pediatrics, but pregnant mothers carry the baby that we're going to be taking care of. So mothers that are pregnant and have HIV, it would be a good thing if they had these highly active antiretroviral therapy, and that we do that before at 22 weeks and then right after birth. Now, remember, newborns are born with no immune system, right? Or only mom's immune system. There is no immune system. So, what is our goal to help this child from the moment they take their first breath? Is to improve their immune function, whether it's antivirals or whatever they need. Again, they need extra, they need to support their immune system. Now, today, HIV/AIDS. You think once the baby's born from an HIV mother, that baby's going to be HIV positive. There's no other choice, right? Well, I'm going to tell you, you're wrong. And I've seen it with my eyes. I was doing clinicals, and it was these three girls, and born from an HIV mother. One had AIDS, one had HIV, and the other girl had nothing. Triplets. I've seen children HIV at birth get the antiretroviral and antivirals following up well, and they autoconvert and are negative by 1 year old. So just because it's HIV does not mean it's a death sentence for the child or a lifelong, wondering, okay? I wanted that very clear for you to know. One of the big things that the children get that can be very harmful is PCP pneumonia, pneumocystic pneumonia. Me and you is a common cold, but pneumocystic pneumonia, especially on a young, brand new neonate, that's going to be trouble. They can't suck, swallow, and breathe. So, again, that's something that we would be watching for. Now, giving blood transfusions, doing apheresis, bone marrow aspirations, blood transfusions, make sure you follow the policy of the hospital. Always know that I think I've seen more reactions with blood than I've seen with any antibiotic, believe it or not. So what I always do is our policy set, take your vital signs before you hang up the blood. Of course, 2 nurses witness, yes. And then if in 15 minutes after you start it, take another vital sign. And then every hour, and it's up to 4 hours of the transfusion. It's at that 15 minutes. I've seen them go from no fever to 101. What do you do first? Turn it off. Turn it off. That's it. Don't wonder, well, maybe it was. No, turn it off. Don't go any further. It's better to get another bag of blood than it is to worry about that one, okay? Apheresis, like I said, it's something like dialysis, but it removes components. It can remove platelets, or it can remove that iron in iron chelation therapy. You can get whatever component on it, okay? And then bone marrow aspirations. Have you ever seen or been a party to listening to what these sound like? Well, think about that blue thing, and the next picture, next slide has another one. It's a huge needle, and they take their hand, and of course, they numb it on the outside, numb it down in, they do the best they can. And then they push it in and go, and then it gives into the iliac crest. That every time I think about it, and it sounds just like that, to tell you the truth. And they get into it and they can pull out whatever they need for testing it. Now, please tell that poor little child that it's going to hurt a little bit, but you'll do everything you possibly can. Most of the time with bone marrow aspirations, they're going to give them some happy juice, some midazolam, some Versed. They don't need to hear that because I think that would scare them even more than the positioning, etc. So both parents have the trait, sickle cell trait. What's the chance that one of each child's going to have the disease?
You said 25%.
Yes, it is 25%. Very good. Thank you, Joy. Okay, cancer. Let's talk about some lymphomas and let's talk about some leukemias. Now, leukemias, there's ALL and there's AML. ALL is the most common and it's the easiest. Not easiest, but it's easier to cure than AML. AML is a little bit trickier. It needs a little bit stronger stuff for whatever reason. It is actually, believe it or not, the most common form of childhood cancer is a leukemia. Boys greater than one. And look at this, poor Down syndrome children are at higher risk for leukemia. So we have congenital heart disease, we have leukemia, we're going to talk about hypothyroidism. Oh, and there's more, but poor Down's children. Today, though, survivability is really good. They have come a long way in their treatment. Now, what exactly is leukemia? It's an unrestricted proliferation of immature white blood cells in the blood-forming tissues, which means white blood cells are being made, but they don't work. They're like been half eaten up by cancer. They don't work. They're cancerous. So no white blood cells means what? No immune system, which means this child is immunosuppressed, very immunosuppressed. So what would you see with leukemia? Well, again, I've got another story for you. My next door neighbor had a girl and a boy that my children played with, same ages. And the girl, about age 12 or 13, was complaining of feeling tired, exhausted, no energy, and just fevers and ached everywhere, and her neck was swollen. Oh, and her knee was hurting her like horrible. She had some bruising and petechiae on her legs and arms, and oh, she felt miserable. So they took her to the ER. Listening to what happened, they did a CBC and a blood smear on it, and they found out she had leukemia, ALL. Well, I want to know that today she's a PhD in psychology from the University of Miami. So she came through it the other side. But can you imagine? It's exactly the symptoms you need to know what you're going to see. Now, you're diagnosed. We've looked at the central nervous system, making sure that, it's not anything in there. And then we're going to be starting our chemotherapy. Now, depending on the type of cancer, depending on what they see in the bone marrow, it depends on what type. It could be 1, 2, 3 types. Strong chemo is given the first 4 to 6 weeks of treatment. That's when that intense, lose the hair, vomiting, miserable goes on. Now, do you see this? Induction therapy, 4 to 6 weeks with the goal of achieving remission after 4 to 6 weeks. Now, they don't stop there because there might be things hidden around up around the corner and they don't know, and they'll go and do that central nervous system. Let's knock it out. Let's to be sure, and let's do some more to make sure that nothing's there, and then there'll be a maintenance therapy, usually oral by that time, and they usually will go from there. But I think it's 4 to 6 weeks of feeling horrible, but then the cancer should be gone. Now, many times chemo doesn't work, and the child needs to look for a hematopoietic stem cell transplant. Now, at birth today, many parents are faced with, do you want to save the baby's cord blood? And that cord blood, the storage costs a lot of money. And most new parents say, I just can't, there's no history in my family. I can't, it's either eat or save cord blood. So they don't. Now, if they had saved it, that sort of transplant is autologous, which means automatically mine is the best. Autologous, automatic, mine. That's the best. Now, bone marrow transplants do not need to be matched as an A, B, negative, positive. It doesn't matter. The best donor is yourself, of course. They say all the others are allogenic stem cell transplants. Of them, the best are your siblings, but you can get it from anywhere. They just have to make sure that it matches whatever they do the match with. Okay. Leukemia, it's a long treatment. They're going to get a port put in before they start chemo. They're going to be going through getting blood and platelets and all sorts of things. They're going to be in pain. They're going to be nauseous, vomiting, losing hair. They're going to be constipated from the pain medicine, and all of these things this child's going to face. So the nurses, we live it with them, just trying to keep them and the family comfortable. Now, we know that leukemia today, the prognosis is really good. We know that it's depending on the white count when you come in. Like the friend that lived with my children's friend was 0.1, but I've seen it as low as 0.01, which is nothing of a white cell count. That one's a harder one to cure. It depends. Is it the ALL or AML, right? ALL is easier. Girls are easier than boys. And that karyotype analysis. What type blood are you? Are you a rare blood type? So that when I need to get a blood transfusion or a platelet transfusion, it's easily, readily available, or do we have to go searching for it? That delay could cause problems. Cancer, we do many things, radiation, we do chemo, we do surgery, all for different reasons. And again, what do you see? It's all those things that I told you my neighbor had: pain, fever, ecchymosis, petechiae, and that lethargy, just feeling horrible, lymph nodes. This is like classic signs that you might see in detecting leukemia. Now, this slide is in the leukemia slide, and it shows a neutrophil count of 500. And what's the importance? Well, neutrophil count should be well over 2,000, or at least at 2,000. A child, an adult, any person with a neutrophil count lower than 500 has absolutely no immune system. And then if they have a fever, that adult is about to go into septic shock. So if you're given a group of patients to go out and visit, and they say, this one has explosive diarrhea, this one had surgery yesterday, this one has a neutrophil count with a fever of 100.8, Oh, that's the one I'm going to first. That would be something that would be priority, not necessarily has to be in cancer, could be any sort of condition with a low neutrophil count. Now with chemo, we know that there's hemorrhages. Again, planning activities for children during this time. Riding bikes and whatnot can cause bruising and damage. Of course, we don't want to do that, but we want them to be able to do some sort of activity. Giving meds before they're sick is important. You know, when I started nursing, you couldn't give an anti-nausea med until they vomited. Is that ridiculous? I'm nauseous. I can't give it to you until you vomit. So I would say they vomited it and I would give it so they wouldn't vomit, right? Poor patients just, they realize you need to give it. Altered nutrition. These children usually get swelling in their mouth and ulcers, and then, of course, they're nauseous and the chemo and they're not eating well. So, what they say is make maximum benefit for every bite of food. High protein, high calorie, high fat in the smallest amount to get the most nutrition in a little bite. Okay. And monitor the height and weight, making sure that they're not losing weight because you need still nutrition, 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 especially, right? As I said, mouth to anus can be all irritated. There's things we can do, types of food not to eat. And then remember, I said they're constipated. Remember, if they're bearing down hard, they can have strokes. Remember, their platelets are low. All of that pushing hard could create that scenario. Be aware of it. It does happen. Okay. They should be on stool softeners. And that's one thing a nurse would say, hey, we need a stool softener on them. They haven't had a stool since yesterday. And those are things that nurses remember, not the doctor. I just wouldn't want anything to happen to any of the kids. They already got enough going on with cancer, right? They can have bloody urine and, of course, that loss of hair. I mean, how many times daddies, brothers, uncles, granddads gave their head for their daughter, right? Or their son. I used to make ribbons. I mean, every time I went to Walmart, there's these little spools of all different colored ribbons, and I'd make little rainbow things every day, every time I worked for these type of children. And I would send one home if they had a sister or if they wanted one for their mother. And it took their mind off what was going on, distraction. Another thing is we give a lot of steroids, anti-inflammatory, and they can get big and puffy. Now, little kids don't really care, but the older kids, body image, be aware of it. Getting them prepared for procedures. We know how to do that, get on their level, explain on their development. And of course, using whatever numbing everything you can use helps. Pain management, giving medicine on time, and then filling it in with maybe acetaminophen or ibuprofen in the in between, if you can. And again, it's not just medicine, it's that distraction, it's the TV, it's the music, it's a game, it's a sticker, it's a something, a toy. Get their mind off of it. Children respond very well to that. With health promotion and your child with cancer, you've got to be careful, specifically with immunizations. Yeah, you still get the dental work, all of that, that's given, but immunizations, what do you give and what don't you? Well, immunosuppressed do not get any live virus, period. But then families, what can they take? They can have some, not the other. And the one thing is they're highly susceptible to varicella, and varicella can kill them. It's a dangerous, dangerous, dangerous virus to a child with leukemia. So they will get an immune globulin of that to protect them, guaranteed. Okay, I'm going to give you an answer to one question on the exam, but you have to listen to me because everybody mixes it up. 50% will get it wrong. So here we go. Lymphomas. We have Hodgkin's and we have non-Hodgkin's. You don't need to know who does what and what age. No. Hodgkin's is a lodge. It's a house. It's the lymph nodes above the shoulders, supraclavicular, and you see them sticking out. painless, hard cervical nodes. It's a house, it's a lodge, it's a hodge. You can touch it, you can feel it. You see it, I can feel it, okay? What happens, it grows and it will push over against the airway and the esophagus, causing GI problems and respiratory problems. And we diagnose it by doing a biopsy on it, and we look for the presence of Sternberg reed cells. So Hodgkin's is a lodge, it's a house, it's touchable, I can feel it, I can see it, and it's painless. It's above the shoulders. We treat it by doing a radiation on it. Let's shrink it up. They use a lot of those purple dye things. Remember, if you ever see them, those marks, never take them off. They need it to do the next treatment because that's where the gun will go with the next radiation therapy. One of the thing about Hodgkin's disease with the radiation and the chemo, there is a high risk for infertility. That's the one thing about Hodgkin's. Lodge, big, large, I can touch it. Now, non-Hodgkin's lymphoma. It's not a house. I can't feel it. I can't see it. It's diffuse. It's everywhere. And if you look at the pictures, it's down lower in those lymph nodes. Okay. So I don't see it. I can't feel it. It's not a Hodge, not a lodge. It's diffuse. Again, you'll do a biopsy on that one. If we can find out where it's coming from, we'll do the same sort of treatment, radiation, chemo, and we'll cure it in that regard. So Hodgkin's, big, large, I can feel it, touch it, above the shoulder, supraclavicular, and then non-Hodgkin's, diffuse. I can't feel it, I can't see it. It's not a house, can't touch it. All right, nervous system tumors. So brain tumors. Most common solid is in their brains. What would I see? Well, you have a tumor and now it's growing, it's occupying space. So when it occupies the space, it creates pressure in the brain. So it creates headaches that are getting worse with time. Symptoms will get worse in time. Also, pressure in the brain. I'm going to be vomiting, right? Not related to eating at all. I'm just going to the pressure on my brain and I'm just going to vomit. Those are usually the two things they start. And then maybe a little bit of stumbling, falling, not walking. I'm a little bit crooked, that ataxia you might see. But if you let it go further, hydrocephalus, diabetes insipidus, that means there's a lot of swelling going on. And that's right behind the nose, the pituitary gland where diabetes insipidus and growth failure is. How do we, number one, treat it? Well, number one, it's those signs and symptoms. It's everything getting worse over time. And we'll do the regular x-ray, CAT scan, do an MRI, and figure out what the plan is. Know that any patient with a brain tumor, they don't want to do a lumbar puncture. And why? That tumor is pushing and putting pressure and pushing all the cerebral spinal fluid. And then you try to do a lumbar puncture, it's going to release that fluid quickly and the brain could fall and shift. And now you're in trouble. So we don't do any lumbar punctures. Now, brain tumors after surgery, they're sort of scary to look at. You know, the first day they're going to have big, teepees, turbans on their head, but then eventually they'll come off. And yeah, it sometimes looks like that. They'll do radiation therapy, they'll do chemotherapy, and then they'll do surgery on the child, trying to get the least amount of brain out they have to. Now, stopperably taking care of these children, it's quite a chore. How do you elevate the head of the bed? Do you turn them on that side that had surgery, or do you turn them on the other side? Watching fluid intake, no fluid overload. You don't want to put pressure in the brain by, fluid overload there, too much fluid given to that child, right? And of course, keeping them comfortable, keeping them calm, etc., etc. Now, neuroblastoma, I just mentioned it to say this. It's a tumor that starts in the abdomen that gets big. And by the time we even see it, it's already metastasized into the brain. And outcomes are not good. They're very, it's not that often in newborns and children. So but I had to mention it because I've seen a question on it. So, bone tumors. When we think of bone tumors, what they're suggesting is the femur bone, where it all of a sudden, what happens is you'll have a child who all of a sudden starts complaining of uncomfortable around the knee area, that on the leg, or maybe in the hip area. And in time, it's getting worse, and then you're starting to limp, and then it gets to the point where you're having those signs and symptoms of fever, the respiratory distress, weight loss, all of those can occur with it. Now, how do we treat a bone tumor? Well, you can't just take the tumor off the side of it. The whole bone has to be removed. The whole femur bone has to be taken out. So they've done all the x-rays, they've done the biopsy. Yes, it's cancer. They've done the radiation, the chemo, and now what they have to do is get that cancer out of the body. So they have to take the whole leg at the hip joint off, and they take the lower leg below the knee and put it up, turned around into the hip socket to salvage the limb to have a place where to put a prosthesis. Yeah, wild, isn't it? It's a long surgery, but it works actually very well. I had never seen it, but I worked with another professor who's seen it several times. And she goes, yes, it is a long surgery, but when it works, it's wonderful. Can you imagine not having anything to put there as a prosthesis to be able to move around? You have like a hip joint, nothing's there, it's just there. Wilms tumor, kidney tumor. The thing about Wilms tumor is if you touch it, it's fragile and it will metastasize. I met a boy who came here from Haiti after the Haitian earthquake. And this religious group brought him in and delivered him to me. And I said, so what's going on? They go, I don't know. They said to go to Miami airport, pick him up, and bring him here. So that's what we did. I said, oh, okay. And they handed me the chart. It was in French. So here I have this young 3-year-old boy. I don't know what's going on. And now I had to do an assessment. So I really had to assess well. I also had to speak to a little boy who speaks French, and I parle un petit peu. I mean, that's about it for me. So we broke the ice. I had him giggling. We did vital signs. When I felt his left lower quadrant on his abdomen, I felt a softball size lump. And for some reason, I knew that was a Wilms tumor, and it was. The end of the story, they did the ultrasound, they figured it out. He had surgery, radiation, chemo. We got him back to Haiti, and he actually sent a note back to the unit that he was at. Somebody knew English to send it for us, and he was doing really well. So that is a Wilms tumor. Big thing, do not touch the belly. That's the big thing. And then post-operatively, because if you look at that incision, that's a Wilms tumor incision. They have to fillet the abdomen open to go deep inside, underneath all the intestines and whatnots. So post-operatively, you're talking about an ileus many times. That the intestines are like, whoa, you manipulated me too much. And then, of course, it was on the kidney. You're going to also be monitoring for urine. Retinoblastoma, it's also called a cat's eye. Ever see an animal outside in the dark with a light and you see that white shiny? Well, this is what happens with retinoblastoma. That's not normal. That usually doesn't happen. I've seen it once. It was like an 8-month-old little girl, and it was all of a sudden I looked at her eye and it was white. Um, One of the things about retinoblastoma is you should find out they're going to be doing radiation, chemo. They're going to do an enucleation. The eye's coming out. They got to get the whole thing in the capsule, the retina and the eye. It comes out. Many times they end up with a prosthesis later on in life. So it always looks like they have an eye, but it's only one eye that they do have. One of the things as nurses and medical, was there a way that we could have determined this sooner? Like, was there something that happened? Are there a lot of infections or, you know, anything unusual? Signs and symptoms is what I'm talking. And now germ cell tumor. Now testicular cancer. And you're like, oh, children, they don't get it. Yes, they do. I've seen it with an 18-year-old boy. Came in, testicular pain. And again, he had this really large, like almost a melon, is what the other nurse said, tumor. And they did the ultrasound. They actually did an X-ray of his chest and his abdomen. And on arrival to the ER, he had already metastasized in his chest and to his abdomen at 18 years old. So women, do your breast exams. Men, do your testicular exams, because it was a really good thing, as an example. This gentleman, this 18-year-old boy, he died 3 months later, we found out, from the first meet. So it is a serious thing. Liver is pretty cool. The liver will grow back. It's the only organ that does that. That cancer survivor is getting more and more than ever. I mean, who doesn't want to see one of those Facebook pages, cancer free? I mean, I've worked with a couple people and couple communities around me with children going through doing walkathons and all sorts of different things. And if you believe in it, it actually does make you feel good. Any questions? All right, let's quick do the cahoots. I'm going to run through it as quick as I can to get you out when I told you I probably would. So I might like cut it off quick on you, which I don't think you'll mind. I don't do it too quick. I think there's like 44, if I'm not mistaken. So, Daniel, you're going to win today? Oh, come on. All right, Shanika, you're going to do it, right? You're going to win? Who wants to
Yeah,
win?
I want to do it. I'm gonna do it.
There you go. There you go. I'm going to go ahead because I think you guys are just tired today. It's that hump day moment. Week 6. It's amazing. We're going over to the end of it. What is priority treatment for a newborn of an HIV positive mother? What's our biggest concern?
Oh,
Newborns
I didn't get in
born.
quick enough.
They just scammed
I,
me
I
with
missed it
my
getting in.
code.
You missed 8240591. Go to kahoot.it. Okay, again, HIV positive mom, infant doesn't have an immune system, mom doesn't have one, so we got to do something to help that infant, improve the immune system.
You said it was 824.
What are symptoms of sickle cell anemia? 8240591. So sickle cell, remember, anywhere there's a blood vessel. So yes, hands and feet and knees are usually your first thing, but no, it can be an eye, it can be a head, it can be a chest, it can be anywhere. Don't say that because it's the head, it's a sickle, because it could be a stroke going on. So that's where you have to be careful with this disease. It can be tricky on you. What kind of hematocrit does someone with sickle cell have and why? Well, is this one of those that die quick or do they last? Or do they don't work at all? Remember, sickle cell children, their hemoglobin hematocrit, I'm happy if I got a 7. They're low and they die really, really fast. And it's usually why you're giving blood in the emergency room, which is a hard thing to do because it takes time and really monitoring and to be safe. So it is lower. Remember that one. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? What do you do first? Are you going to treat a symptom or treat a cause? And that's the answer to the question. We are going to treat the symptom, no, with a cause. It's small blood vessels. Let's enlarge them. Let's put heat on there and let's get the blood flowing. And then in my other hand, I've got the pain medicine at the same time. What is the reason children with iron deficient anemia are easily tired? Hmm, anemia. I don't have enough red blood cells. I have no oxygen. I have no iron. And yes, I'm tired. A multi. The nurse is teaching about a newly prescribed iron supplementation. What should be included? One of the recent essays had a question about iron and children on it. And that's why I made sure that it's in here on the hoots. It's not always on an exam. You might see it on a HESI, putting it into that, spot during the week where it makes sense. So on an empty stomach with OJ through a straw, prevent those teeth from getting, browned. Tell them the stool's going to turn black. Yes, never with milk and never after it's before meals. Good job. Aplastic anemia includes a depression of which cells? I think this is of all of them. This is the worst one. It's like, where do I turn? It's like you got me everywhere. And it's red blood cells. So we're talking iron oxygen, white blood cells, infection, platelets. We're talking bleeding. That's a rough one. Most common type of anemia is iron deficient anemia. Yes. What causes pernicious anemia? B12 deficiency. Very good. Which symptom is the single most common symptom of anemia? Tired, fatigued, yep, and lazy. Very good. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Well, what does beta thalassemia do? Rectangular cells, they burst. What's our concern? So the cells burst, so I don't have oxygen, so chronic hypoxia. Also, iron is spewed in there where I need iron chelation therapy, whether apheresis or medication. So that's the answer. You need to know that one. What lab values will you see with hemophilia? So with hemophilia, just the normal labs, PTT is prolonged, but the normal prothrombin time, which is that Coumadin one, and platelets are both normal. And that's that telltale sign. Okay, we know what's going on. What is immune thrombocytopenia purpura? ITP. As I said, what does P stand for? It's decreased number of platelets. And remember, ITP is about bleeding, not enough platelets. It's one of the bleeding factors that you need. Thrombocytopenia can cause the following symptoms. So it's all about anything with bleeding, whether it is, little tiny little purpuras, ecchymosis, bloody nose, all of those things. Any bleeding. Multi. A child with hemophilia has fallen, the knee is swollen and painful. Treatment would include what? So we're not going to move the knee. We're going to rest it. We're going to put ice packs on it because we want to stop bleeding. So we constrict it. And then, of course, elevate. So rest, ice, contain, and elevate. What is the priority nursing action for a suspected blood transfusion reaction? What do you do first? Turn it off. Very good. A child's admitted with neutropenia. Which nursing action takes priority? When we're talking about neutropenia, low white count, it just means the child's more apt for infection, so you need to be safer. How are we safer? It's the hand washing. Always starts with hand washing. Which symptom would a healthcare professional expect to see in a child with leukemia? What symptoms? So the bleeding thing, bruising, fatigue, tired, hemoglobin hematocrit are low, and then the pain. It's usually a bone pain, a knee, a hip, or something. Your child with ALL has recent lab results with platelet counts of 10,000. What is your nursing action? Now, I'll tell you, just because you have ALL doesn't mean that you'll have the platelet counts of 10,000. Many things can cause you to have a platelet count of 10,000. Our key concept here is about you do about low platelet count. And that's all about bleeding precautions. Very good. A multi. A child's based on bleeding precautions for ITP. What interventions would the nurse do? Yeah, the child, come in. Find out they had a viral infection, upper respiratory, and now their platelet counts are low. They're being admitted. We want to make sure that they don't bleed. So no injections. We're going to be looking at it. We're also going to be watching their CBC because most likely it'll be done every morning, looking at platelets. Is it getting better? And of course, the corticosteroids. Child with a Wilms tumor. Why action by the nursing student causes faculty member to intervene? Remember, that tumor is extremely fragile. They don't even do biopsies of that tumor preoperatively. That's how it would leave a hole in it and let it metastasize in the belly. So you don't even do that. A child with ALL has a fever of 100.5. What should they do? Any child that's autoimmune that has a fever of 100.5, what should they do? They need to tell their doctor or they need to get to medical care because there is no immune system when you're talking about immunosuppressed like ALL. They need antibiotics started now. Child is having a bone marrow aspiration. What should you tell the child? Do you see the size of that needle there? It's huge. And I can think not only when they're doing it, but afterwards, that big hole. Anyway, always be honest. It's going to hurt a little bit. We'll try to make it as best as possible. Most common clinical manifestation of a retinoblastoma. Remember, this is what you see with your animals outside, that white thing. We call it cat's eye reflex. And remember, they got to take the whole eye out. Your child has been diagnosed with retinoblastoma. What information is important? Like, what's part of the assessment should be asking about? So they have an eye problem, there's a tumor. Tell me, has there been any problems up to this point? Are they complaining of pain? Or do they have headaches? Do they have any sort of information that can help the doctor with that? A goal of surgery for a child with osteosarcoma is what? Remember, osteosarcoma, they're talking about the femur. And remember, they've got to take the whole thing out. They can't just leave a piece of it. So what they want to do is they take the whole leg off, take the bottom of the leg, put it on, turn around, put it up, and then they reattach it. And then that part of the limb, that salvaged limb, becomes the area where a prosthesis can go and they can walk and be ambulatory. A child's complaining about those skin markings for radiation therapy should be told what? Those purple things. It's always purple. So these are extremely important. They actually take a lot of time to measure it out and put those marks on, so you don't want to brush it off. When distraction is used, it helps. You'll always get questions from another week, concepts that you should know. And we know distraction in children is great because they're thinking about something else, not about them hurting. What assessment question needs to be asked to a child with possible rheumatic fever? Yeah, another one from last week. Rheumatic fever is caused by strep throat that was not completely treated, and we treat it by long-term antibiotics. Signs and symptoms of asthma. So coughing, shortness of breath, and it's always expiratory wheezing. Remember, croup is the inspiratory. It's all upper. Air can't get in. But asthma, it gets down and it gets trapped and it can't come out. And that's that wheeze when they try to breathe air out. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? I mean, these are more dangerous symptoms. I mean, we know that sickle cell, causes swelling, yeah. But each one here is like scary. And it's the headache and the chest pain. Is it a stroke? Is it a pulmonary embolus? Or is it a sickle cell crisis? What is it? It needs to be ruled out. An absolute contraindication for nasal tracheal suction include which of the following? So anything that swelling would create no airway, and it's all the above. Very good. Iron dextran is given via which route? This was my first IM injection I had to give as a student. And it was on a young 40 some odd year old woman. And let me tell you, I had to do a Z-track for my first injection. I was lucky. The lady said I did it well, but can you imagine Z-track, first one? But again, put it in, lock and load, because it holds that material in that can stain the skin, and it can burn also. A child was to receive their own bone marrow. This is called a blank transfusion. Automatically, mine is the best. Autologous. Very good. What cancer may present with painless, firm, and enlarged cervical nodes? Hodgkin's lymphoma. Good job. Multi. When teaching about sickle cell disease, you would include what? So sickle cell disease, we want to keep hydrated, especially young children. We don't talk about it, but what about going up in an airplane? They should be well hydrated because of that pressure, right? Also, it's cold outside. They need to dress warm or it's going to constrict vessels, causing another clog up of the blood vessels, okay? Another thing, pain medicine. Sickle cell disease, the pain can be really bad. And they are given prescriptions to have at home for when they start to feel it. They can start it before they come in and get, the more strong stuff, the morphine, hydromorphone, or something else. And of course, that 100.5 temperature, any immunosuppressed. Thalassemia major is treated primarily with what? And if you look at that picture, that girl has thalassemia. It's like her jaws were bigger, like the marrow in there were enlarged. And she has the deformity of the face like that. Yeah. And it is all about blood transfusions. Their cells die quick. They spew oxygen and iron, and they only need blood transfusions to live. Their own doesn't work. A multi. Treatment of an osteosarcoma includes so when we're talking about osteosarcoma, or that's the femur bone, it's either amputation or it is salvaging the limb. Yes, we'll do chemo, try to break it down. And thank you for not trying to pick stem cell. That has nothing to do with bones. That's usually blood. A multi. Who are the best donors for a bone marrow transplant? So if it can't be me, who's the best? And that's going to be my siblings. Mom and grandma are not as good as siblings or yourself. What is the most common opportunistic infection for children with HIV? I remember when HIV came out, and it was in the early 80s. And I was working down at the county hospital in the medical area. And I had an HIV patient who went into respiratory arrest from PCP pneumonia. I had never heard of it and what it was. And then I found out that it's you and me, it's a cold. But for a patient with HIV and no immune system, it will knock them out and it can cause severe respiratory distress. What would you consider to be neutropenia or a low neutrophil count in children? So less than 500. We know it's somewhere about 2000, the normal, but less than 500. Remember, that's a child or an adult, especially if they have a fever. That one's going to crash and burn and go into septic shock if we don't get treatment now. A primary characteristic of a brain tumor. Got this growth in the brain and it's starting to grow. And it's that symptoms worse over time, headache worse over time, vomiting not related to eating. Very good. The optimum treatment for an osteosarcoma is what? What is our goal? What is the best outcome? As crazy as it sounds, right? And it's salvaging the limb because we want somewhere to put that prosthesis. Let's see how we did today. Child is receiving the induction of chemotherapy. What does that mean? Induction. The first 4 to 6 weeks of chemotherapy, and they hit them with everything. And the goal is remission. Very good. You guys listen today. Dan the man. Good job, Dan the man. Number 2, Jazzy. Number 1, Moni. Job, Moni. Number 4, Tommy and so we are done with today. Interesting subjects. Remember that we have our reviews this week. I will be posting them as I get them. Remember next week to come and be prepared for exam. Try to get here a little earlier so we can get out earlier afterwards. Usually I do a cahoots after the exam, and that feeds up just about the right time. And I know I'm hitting all the concepts you need on that cahoots. Any questions, comments, any concerns? Thank you for a great class.